And that means less blood is going up to your brain, right? So what happens is that's a temporary lack of perfusion for your brain. And by all rights, you should be hitting the floor, blacking out. Well, your baroreceptors are very quick to respond to that. They instantly detect the decreased pressure, send fewer action potentials, and the resulting output is sympathetic in nature. More vasoconstriction, restore the pressure on the blood. Are you hearing that? We've lost blood pressure because our blood is pooling somewhere else, and now we want more vasoconstriction to restore the pressure. Let me say that again and again. We need pressure to get perfusion, right? Our pressure is our driving force for flow. If you do not have adequate pressure, you will not have adequate flow. What's the best, fastest way to restore the pressure on the blood inside? Reduce the radius. Get the pressure back on the blood. That helps with systemic flow. Are there people that have problems with these baroreceptors? Yes. This is called orthostatic hypotension. And if you're drinking alcohol or you're dehydrated or as we age, this is one of the new ones, I'll wait. Did you find it? Okay. As we age, if you're drinking alcohol excessively, if you are on excessive bed rest, with excessive bed rest, I mean, there's lots of changes that happens in a patient with excessive prolonged bed rest. I will tell you some, but we don't have time for me to go into all the physiology of bed rest, which is a really cool topic, don't get me wrong. But with prolonged bed rest, you also get decreased blood volume and therefore pressure. So if that person's in bed rest and you suddenly ask them to be ambulatory on their own, they're going to have orthostatic hypotension. They won't respond appropriately. So they're going to come crashing down. You better be around to help them. So what do we do? Who else can have orthostatic hypotension? If someone has arteriosclerosis, if they have abnormal calcium deposition in their arteries, it can actually impair baroreceptor function. And so when they stand up, their baroreceptors do not respond appropriately, and they don't have the pressure restored on the blood inside as they stand up, and they can pass out on you. So lots of reasons why a person, and Joy was talking to me about a friend of her daughter's today that had a viral infection, and now she can't even sit up for more than 20 minutes.
Right.
Or walk. So we do a tilt table test. We have them lay down on this table. We strap them in, of course, because if they do have orthostatic hypotension, we don't want them to fall. We have a blood pressure cuff, and we're monitoring that blood pressure. And then we tilt the table upward. And orthostatic hypotension is a drop in systolic pressure of about 20 millimeters of mercury or more, or a drop in diastolic pressure of about 10 millimeters of mercury or more. So that is what we do. We also can have people have orthostatic hypotension if they're on antihypertensive drugs. So if they're on a lot of diuretics or calcium blockers, they might stand up and feel, my mom's on diuretics, and in the morning when she's just taken them, she has to be careful about when she's at the soccer game, she's playing with my little nephew, and he's like 30 pounds and he's just a year old, and she has to be really careful getting up with him because she feels like she's dehydrated from all the urine output that she's had. So patients who are on antihypertensive meds can have orthostatic hypotension.
So I thought the whole point, like they use diuretics for people with high blood pressure. So how does that, I mean, is it just reducing the blood volume? Is what's actually reducing the blood pressure?
Yes.
So then why would they do that? Because then they couldn't lead to
Not everybody gets this.
Okay.
So there was, let me try. Arthrosclerotic research in community. There is a series of studies. I'm trying to remember. I was just looking at it last night. Atherosclerotic research in communities, something like that. ARIC. Anyway, they were studying orthostatic hypotension in these people who had atherosclerosis. And they noticed that people who were on meds had a greater tendency of having this issue, but not all. Some that weren't on meds and had the arteriosclerosis had a greater tendency, but not all. And they also did learning tests on them. And they learned that the ones that did have this actually had poorer memory recall and couldn't solve tests. Anyway, they did a whole bunch of stuff on them. Long-term blood pressure being too high is a lot worse than dealing with these episodic moments where you feel like you might be a little faint. So they actually, from those studies, because your question is valid, they did a flow chart. Does a person have OH? If yes, next part of the flow chart, is it drug-induced? If yes, following the drug chart, can they stop taking their medicine? If yes, answer, then stop. Literally, that's what it read. If no, then can you reduce the drug? So that's what they were trying to do in these people. If you want that paper, let me know. I'll upload it. Carissa?
You said just sort of the ANS, so like if someone had like hit part of their brain or something, it could affect them having like fainting spells or...
You don't even have to have the brain. How about a spinal cord injury? Mm-hmm. Sympathetic nervous system, T1 through L2.
Oh, okay.
So if you disconnect the brain communicating to those preganglionic fibers, you just wiped it off the board. Diabetes. The complications of diabetes, they can have neuropathy and they can have problems with orthostatic hypotension as well. Okay, so if your blood pressure rises, your baroreceptors detect more stretch. They send more action potentials up to the medulla oblongata. That means you're going to have decreased vasomotor activity, more vasodilation. That means more pressure on the blood, and blood pressure will drop. We will have increased parasympathetic output and decreased sympathetic output. That means more acetylcholine released on the heart and less norepinephrine released on the heart, and therefore stroke volume and heart rate will go down, decreased chronotropy and inotropy, and that means decreased cardiac output, which means less blood pressure. Could we do it again for the reverse, where we have too little blood pressure? Sure, we could. Okay, what other receptors do you have in the same place? You have chemoreceptors. They're in the aortic arch and the carotid sinuses. They also can change, or influence, I should say, the same centers in your medulla oblongata. Here's the thing. If your chemoreceptors detect less oxygen, if they could talk to you, this is what they would say. Oh my gosh, we're not getting enough blood flow. We're not getting enough oxygen. And they are going to stimulate the vasomotor center and cardioacceleratory center in the medulla oblongata, and that means more sympathetic output. So a decline in oxygen is going to send more action potentials up to the sympathetic nervous system. Sorry, let me rephrase that. A decline in oxygen will stimulate the medulla, the vasomotor centers, and cardioacceleratory centers so that you get more sympathetic output. And you get heart rate and force of contraction going up. The Bainbridge reflex is another reflex art that we should consider. This is going to prevent damming of blood in the veins in the atria and the pulmonary circulation. These are stretch receptors in the atria. So if you have more blood coming back to the atria, it's going to, these stretch receptors detect more blood pressure and volume, more stretch. We're going to have action potentials sent up to the medulla oblongata. It's going to have more sympathetic output. If it could talk to you, it would say this: whoa, we just got a whole bunch of venous return here. If we have more in, we need more out. Of course, we recognize that there is the Frank-Starling mechanism, the intrinsic mechanism, but when we have more venous return, we're also going to have the Bainbridge reflex provoking the sympathetic response, which means more calcium availability and more contractility. And that was on that nasty little flow chart that Martha doesn't like. Okay. The microcirculatory system. We're talking about capillary beds. I told you earlier we have 10 billion capillaries. Remember I was saying we were plucking them out of the body, and collectively they have a very large cross-sectional area, about 500 to 700 square meters. They are exchange vessels because this is where blood pressure and flow rate are optimal to allow nutrients to be dropped off and waste to be picked up. But you know what? Those aren't the only reasons why. There are 4 physical pressures in a capillary bed that dictate how much fluid leaves the capillary and enters the interstitial space to become interstitial fluid, and how much of the interstitial fluid goes back into the plasma, carrying with it the waste from the tissue bed. 4 forces are going to regulate the fluid leaving and coming back. Most of the substances are going to rely on diffusion. The fluid is going to go through the intracellular clefts to the interstitial space, but we still need nutrients to diffuse to the cells. They have to be within about 20 microns worth of a distance from a capillary bed in order to rely on that diffusion rate, in order for it to happen in a quick enough fashion where the cells can survive. So it'll be concentration differences that will direct this diffusion. What do I mean by that? We've learned diffusion. Blood that's arriving is rich in oxygen, yes? That's an oxygen source. The tissue outside the capillary bed has been using it. That's an oxygen sinkhole, right? We have a gradient. Oxygen will diffuse out of the capillary to the tissue bed. What have the tissues been generating? CO2 and waste. That's a source. The blood is low in that, right? And so those should diffuse into the bloodstream. Okay. All right. There's nothing like the last 10 minutes of class to break in new information. You ready? I don't want you to know numbers. No numbers. Don't care. What do these symbols mean? You see this pi symbol? That stands for osmotic pressure. Do you remember the term colloid? What does that mean? Proteinaceous soup, right? An aqueous protein solution. Okay. What does the capital P stand for? Hydrostatic pressure. Right now, I want to remind you, water moves for 2 reasons. Water moves because of hydrostatic pressure. I can take Taylor's water bottle, I can remove the cap, and without using the force of gravity, I can squeeze on the bottle and get her water to move. That is hydrostatic pressure. Sorry, Anthony. But water will also move if there's an imbalance of particle count across a cell membrane. That's osmotic pressure. All right, We have a hydrostatic pressure in the blood vessel. We have an osmotic pressure in the blood vessel. We have a hydrostatic pressure in the tissue bed. And we have an osmotic pressure in the tissue bed. We have one of each in the vessel, one of each out of the vessel. So far, so good? Okay. Let's start with the blood pressure in the vessel. Which way does it push on the fluid? Out. It would have a tendency to push fluid out of the vessel into the tissue. Good? What is the number one protein in the plasma?
Albumin.
Albumin.